Good morning, everyone, and welcome to the Home is the Hub special topic webinar number 2. My name is Betsy Cole-Archer, and it's my pleasure to welcome you to our special presentation about community health workers in Virginia. Before we get started, I wanted to share a couple housekeeping items to make sure we have a good webinar this morning. The slides were sent to all registrants or can be available in the handouts grab tab of the GoToWebinar platform. This webinar is being recorded. We do ask that if you are able to, that you join us using your telephone option where you'll be prompted to enter an audio pin. This allows you to verbally ask a question during our questions and answer session of the webinar. All participants are muted at this time. You may ask a question using 2 different platforms. You may raise your hand during the question and answer session by locating the icon, the blue circle with the palm in the middle. You'll click that button and I will go to your line and unmute your line. You may also ask a question at any time during the webinar by putting it into the questions portal from the GoToWebinar platform. And at this time, I will turn things over to Abraham Seacrest. Abraham?
Good morning, everyone, and welcome to our webinar this morning in our Home is the Hub initiative, an initiative to accelerate progress to reduce preventable readmissions in Virginia. Just as a reminder, this series is being sponsored by, the Virginia Hospital and Healthcare Association, which is the association of all 107 community psychiatric rehab and specialty hospitals throughout Virginia. So all hospitals in Virginia are members of the association. And our shared vision is, through the power of collaboration, the association will be the recognized driving force behind making Virginia the healthiest state in the nation by 2020. In the summer of 2014, the board of directors for the association, which is comprised of CEOs of all the major systems around the state, underwent a strategic planning process and identified 4 strategic improvement priorities in the area of quality, safety, and service excellence. Those priorities are listed on the screen. Number 1, reduce preventable hospital readmissions. Number 2, reduce healthcare-acquired infections with a specific focus on Clostridium difficile. Number 3, improve the patient's experience of care as measured by HCAHPS. And finally, for all Virginia hospitals to report and learn from serious safety events. Today's webinar, of course, is focused on priority number 1, reducing preventable hospital readmissions. And the association made a conscious decision to focus on hospital-wide readmissions and do deep dives into readmissions from post-acute settings and readmissions related to total hip, total knee replacements, and recognizing that Virginia hospitals are doing many things beyond these 3 areas to prevent readmissions, but these would be the areas in which we'd focus on collectively. As we launched our statewide Learning and Action series, we chose the title Home is the Hub to recognize the fact that although patients are with us for a short period of time, the majority of their lives are spent in their home. And so what we do while they're with us and what we do as we help them to transition to other settings of care, we should recognize that for most patients, their preference is to be in their home. We launched our series in June of last year, focusing on, as I referenced before, the post-acute transfer readmissions, the multi-visit patients, which we referred to in the past as high utilizer patients, and then the total hip, total knee replacement patients, looking at all 3 of those groups in parallel. In addition to those focus areas, we've been very active in engaging our partners in the post-acute settings, working with our partners at HQI for their cross-continuum work, engaging community-based care initiatives such as those led by the area agencies for aging across the state of Virginia, and then emphasizing the effective use of data that's provided both by VHHA and HQI, formerly known as VHQC. Some of the activities that we have planned for 2017 are listed on the screen. I won't read through all of those, but of course we're today focused on community health workers as a strategy for reducing preventable readmissions. All of the webinars listed are offered on Wednesdays at 10 a.m. and the materials and recordings from all the webinars are or will be available on the VHHA website. Today's agenda will focus on community health workers in Virginia. We are glad to have with us representatives from the Institute for Public Health Innovation who will speak to us about the progress being made to advance the use of community health workers in Virginia. And then we'll have two case studies, one from Centera Rockingham Memorial, and then a second case study from our colleagues at Virginia Commonwealth University Health System here in Richmond, Virginia. And then we hope to have time for questions at the end. Before we move to our first presenter, for those of you that have been with us from the very beginning, you will recall that Dr. Amy Boutwell has served as our subject matter expert for our entire webinar series. Dr. Boutwell is not with us this morning, but she did prepare a few messages and thoughts that she wanted us to share with you to reinforce the importance of community health workers as a potential strategy as we attempt to reduce preventable readmissions across the Commonwealth. So, community health workers in healthcare delivery transformation. As we all know, all hospitals are focused on the triple aim: higher quality care at a lower cost and a better patient experience. And so all of us are responding to the market pressures to transform the delivery of care as we pursue the triple aim. The pursuit of the triple aim requires us to develop better systems that will manage care across settings and over time. I think we in the hospital settings have historically been focused primarily on the care that we provide within our four walls. The transformation that's occurring in healthcare really requires us to look across settings. Additionally, we must also look at the behavioral and social needs in addition to the medical needs without attention to quote-unquote artificial boundaries that we may have worked in the past, also known as silos. Dr. Boutwell believes that community health workers can help us accomplish these goals. They can help us engage patients through forming trusting, helpful relationships, and they can also help us help our patients navigate care so that we can reduce barriers through connections to healthcare teams and community-based teams that can, again, reduce the silos that we often work within. Dr. Boutwell noted that in Massachusetts, there's a 24-hospital, $60 million healthcare delivery transformation initiative that's focused on reducing overall hospital use. She notes that among all role types hired in these 24 teams, the #1 hire were community health workers. She also notes that in New York, there is an $8 billion Medicaid delivery system reform incentive program that aims to reduce hospital use by 25%. There in New York, they've looked specifically at high utilization, both in the ED and overall hospital utilization, and most of those teams are seeking to add community health workers, also referred to as navigators, to augment the nurse and social workers' efforts to coordinate care. And they're recognizing that helpful, trusting relationships and direct navigation support are needed to achieve the goals of managing care across settings and over time. One of the questions that often comes up is, how are community health workers funded? What Dr. Boutwell has seen across the country, within Medicare, there are a number of state-based innovation efforts that are funding the use of community health workers and state-based Medicaid reform initiatives. As we all know, Medicare is sponsoring a number of value-based programs, the ACOs, the bundle programs, the readmission penalty avoidance efforts, and she's seen that community health workers are often being funded through some of these initiatives. And then there are a number of what she's referring to as payer blind demonstration projects, and a couple of the initiatives we'll hear about today will reflect those efforts here in Virginia. Finally, she says that we're considering our objectives at our Home as a Hub initiatives to promote quality and to minimize undesirable high readmission penalties. We here in Virginia should consider adding community health workers to our internally funded readmission reduction teams and recognize that they are particularly relevant for our high leverage focus areas, including patients being transferred from the hospital to home, patients transferring through to the post-acute setting, and then finally our multi-visit patients. So that will conclude our thoughts and messages from Dr. Boutwell, and at this time I'm pleased to introduce our first speaker this morning, Sonia Kibler. She's the Program Manager for Healthy and Equitable Communities at the Institute for Public Health Innovation. She will speak to us this morning about community health workers in Virginia and how the Institute for Public Health Innovation is moving that agenda forward. So Sonia, I will ask that you unmute your line and welcome to our webinar this morning. And Sonia, we're not hearing you, so be sure you've unmuted your line.
Okay, can you hear me now?
We can hear you now. Wonderful. Welcome.
Okay, perfect. Great, thanks for the introduction, Abraham. I'm happy to have the opportunity to talk with everyone this morning about the important role that community health workers play improving health outcomes, quality of care, and of course reducing healthcare costs. But also to tell you about what is happening in Virginia so you guys can understand initiatives and movements that are occurring here. Next slide. So when we talk about a community health worker, we're talking about a frontline public health worker who's a trusted member of their community. They usually have a very close understanding of what is happening, especially in terms of culture, race, religion, socioeconomic status. They are very much a peer, if you want to say, for the people that they're helping. So by having that common understanding, they're able to have that trusting relationship so that the community health worker can serve as the link or the liaison between health, social services, and the community member, and in some cases, we'll look at later one of the models with the healthcare team. So this really helps to improve quality, cultural competence, and of course, service delivery. Next slide. So it's important to note, Abraham mentioned this a few minutes ago, when we talked about community health workers, he also mentioned patient navigator. It's important to know that there's a lot of different titles that community health workers are called, and it depends on where they work, what organization or agency that they work for, what they specifically do. So it can be a little bit confusing, but just to remember that whether they're called a community health worker, a patient navigator, a promotora, a health promoter, at IPHI we call ours community health advocates, just to realize that they are community health workers overall. And they're very distinctive, and one of the questions we often get is, how is a community health worker different than, say, a medical professional or a nurse? And first of all, they don't provide clinical care. They may, take blood pressure screenings, or some of them may, take a blood glucose, but in general, they're not providing any type of care, and they don't hold any type of professional license. As I mentioned earlier, they're building their relationship because of all their similarities, and that's what allows them to have more of an in, for lack of a better word, and to really help their patients or their clients. with all the different issues that may be impeding their health care, either access or adherence. So they're able to really make the linkages to housing or transportation, getting to the grocery store, unemployment, all the different issues that happen in real life that are probably directly impacting adherence to treatment, or why they're developing complications and possibly even needing readmittance to the hospital. Next slide. So in the last several years, there's been a renewed interest, not just in Virginia, but also at the national level in community health workers and their roles. I'm sure some of you on the line are experts in some of these fields, but in 2010, the Department of Labor actually included community health workers as an official job classification. So they are considered an actual workforce. In addition, the Medicaid rule changed. So for preventive services, as long as those services are kind of ordered by a licensed provider, then unlicensed providers such as community health workers are able to be reimbursed for Medicaid for preventive services. So that could be basic screening for blood pressure, counseling for smoking cessation, or healthy eating. In addition, the healthcare trend toward patient-centered medical homes, accountable care organizations, and the value-based purchasing, so they've led to a greater interest in different strategies and how do we improve health outcomes, quality, and of course, again, reduce those costs. So when we talk about the triple aim, studies have shown that cost reductions through lower or more appropriate utilization have a return on investment of about 3 to 1. So what that means is for every $3 saved in the ED, the hospital, outpatient services, for every $1 spent on a community health worker. And that includes not only the staff, but also all of their training and associated expenses. So I know Laura's going to talk next about Centara's program, and I think we'll see some more of those return on investment, figures specifically with their program. But in terms of improved quality of care, we have seen improved screening rates, patient satisfaction, and of course reduced hospitalizations, as well as just improved health outcomes across a range of medical conditions, especially the chronic diseases. Next slide. So in Virginia, we actually do have a community health worker definition. When I say that, that means that this has actually been created and adopted by the Virginia Community Health Worker Advisory Group and the Virginia Community Health Worker Association. So I'll talk more about both of them in a minute. But the definition was determined in 2005, basically by a study or a grant at James Madison University. And I'm not going to read this to you, but in the bold are kind of the key highlights that make a community health worker stand out. So unique understanding, culturally appropriate, linking people, advocating for individual and community needs, and building individual and community capacity. So we have tried to get this into legislation, but thus far we have not been successful. Next slide. So I was asked just to bring up the two different models of care. And we have a clinical and a community model. In the left hand, you're going to actually see the drawing of a clinical model. And National Association of Social Workers in Michigan did a great job with this. And when we talk about clinical, we're talking really about integrating them into a healthcare team. So this rarely happens, but hopefully it's going to happen more often. But they actually are part of the team. So you can see from the drawing, it's not only the primary care physician up in the left-hand corner, but it actually includes a social worker, but then the lower right hand, you can see it actually includes the community health worker. So by doing that, the medical provider knows that, the patient could have an issue. So therefore, if there's a community health worker that's part of the team, they can go ahead and communicate with that community health worker the needs of the patient, and the patient can go out, into the community and help the patient. Where when we talk about community health workers, which could be more, the one-on-one setting in the lower picture, not only are they providing, some of those basic services I mentioned earlier, but they're really helping to connect people in the community. So for example, with IPHI, our community health workers here in Richmond are based in the community at the housing authorities. So that person lives in the housing authority as well, knows the neighbors, is very similar, is often extremely respected and asked many questions anyway. And then sometimes they may even go door to door, knocking on their neighbors' homes and kind of seeing what they can do to help. Other times they're sitting in a resource center where other resources are available. Next slide. So in Virginia, we have the structure that I mentioned earlier of the Community Health Worker Advisory Group. There's a couple different subcommittees, but one of the most important is the Policy and Finance Committee. And then we also have the Virginia Community Health Worker Association. There is a lot of history of how this has all kind of evolved, but basically kind of it started in the spring of 2014 with some of the committees coming on 2016-ish. But basically, we're trying to identify initiatives that are currently taking place in Virginia. They're looking at, core competencies, standards of practice. They're looking at different training requirements. And then they're looking at trying to make recommendations on certification and reimbursement of community health workers. Next slide. So the advisory group really is trying to raise awareness of the effort statewide and addresses some of the things that I had just mentioned a minute ago. They do meet monthly. If anyone is interested, the next meeting is next week. And if we go to the next page, the next slide, you can see some of the members. You can have a better look at this later. And this isn't a complete list. I'm sure it has grown since this slide was put together. But basically, it just shows that we have a lot of members, and they come from many different places. So we have community health workers as well as their supervisors. But we also have statewide agencies, free clinics, large healthcare systems, insurers, academic institutions. So it is a wide range of people that are inputting into these different meetings and different activities, so that when we talk about competencies or scope of service or modeling requirements, we're getting a lot of different perspectives. Next slide. So one of the subcommittees is called Certification and Training, and they are looking at some of the requirements of actually certifying community health workers. So this is a new initiative. It's going to be completely voluntary. We are not forcing people to become certified as community health workers. It is just an additional certification if they would like to have it. So this committee is actually forming, they're looking at a lot of different states, Minnesota, Ohio, I think it's New Mexico, Massachusetts, and they're looking at, okay, if we want to certify, what are the requirements? Will there be different stages? How many hours will they need to put in or have worked? What will the training requirements be? How are we going to handle grandfathering in community health workers? And then, of course, kind of the overarching is who's going to be the certifying entity, who's actually going to be the one that monitors and tracks all this and actually gives out the certificates. So they have made a lot of progress. They do have a final copy. If anyone wants to see it, I'm more than happy to have VDH share it, or I can share it, as to where they are on that. The second one is the Policy and Finance Planning Committee, where we work on policy and finance issues. Next slide. So one of the key things is policy and legislative goals. So we need to really address state legislative priorities, of course, for workforce development, because what we're looking at is the sustainability and reimbursement of community health workers so that we're able to achieve the triple aim. But we need to raise awareness among the legislative partners. If they don't know about community health workers, they don't know their value, they don't know their return on investment, then we're not going to be able to legislatively move policy forward. And we need them to advocate for those bills. So one of the big activities we just did, and Laura may have been a part of this, but Centara definitely was we had our first ever Advocacy Day at the General Assembly at the end of January. We had a good turnout. We talked to about 20 different legislators there, and some people knew about community health workers, some didn't, but everybody was well received, and we do plan to make this an annual event now. Next slide. We also put legislation through at the General Assembly this year. The language was developed by Senator George Barker. He was our patron. And so we did have a Senate bill that basically was directing the Virginia Department of Health to form a work group to handle a lot of the tasks that I have just previously mentioned. So while scope of practice and core competency and training and looking at sustainable payment systems is moving forward, we wanted it formally recognized actually in legislation. So we did find our patron and we did put the language through. Our advocates and community health workers and everybody that was at Advocacy Day worked really hard to garner support for this. And fortunately it didn't pass, but we always have next year, so we're gearing up already for that and how we can make 2018 even better. Next slide. So in terms of finance, one of the biggest challenges and issues we have is how to create a sustainable workforce that's financially viable. So we want to increase public and private third-party payers. We want to increase awareness among healthcare systems. We really want them to be part of the integrated healthcare team, but we can't do that just through short-term grants. We actually need a combination of public and private insurance payment, direct hiring of community health workers by healthcare systems, and any other innovative approaches that come along. So as part of this, the Planning Committee decided we actually needed an official policy and finance committee that would be made up of managed care organizations, hospital systems, federally qualified health care, DMAS, and others. Next slide. So that committee was formed last November. They meet twice a year. Our next meeting is May 4th. If anybody is interested in attending, please let me know. My contact information is at the end of the slides. But they're basically high-level decision makers that can really help advise and lend expertise on the issues, help promote legislative and organizational change within their own organization or agency, and just advocate for community health workforce development and utilization. Next slide. We do have a communications subcommittee, and basically I'll just say that there's a blueprint for communications and public relations. Next slide. And they just have a lot of strategies and tools. They're a new group, but two of the most exciting things I'd say are, one, they're going to have a website for community health workers, so this is the first time this is happening in Virginia Department of Health side of our advocacy group, and everything is working on that. Hopefully it will be launched by the end of this month, so keep your eyes out for that. And it's going to be a place, just where community health workers can go to get information. Right now we don't even know how many health workers we have throughout the state, so there's a survey going on, so the results of that will be posted, any type of announcements, speaking events, elevator speeches. And the other thing is that they're creating a logo. So right now there is no logo. So there'll be a logo for the Community Health Worker Association, and then there'll be a separate one for the advisory group as well. and they're really going to focus on diversity. Next slide. So the last movement we have is actually the Community Health Worker Association, because they realized one of the things missing here was really a group that was led by and for community health workers, where they could go and kind of voice their concerns and their issues. We do have a staff person from IPHI that's kind of helping to coordinate them because they're a new group, but they meet monthly, they do have a board, they have bylaws. Right now they're looking at increasing membership. And like I mentioned that survey earlier, we think will really help increase membership as more people learn about them. But they've also been very active in our Community Health Forum meeting we had a few weeks ago in Charlottesville, as well as the Advocacy Day, as well as the Policy and Finance meetings. So really the three groups of the Advocacy Group, the Association, and the Policy and Finance Committee really work closely together to move this forward. Next slide. I feel like I've gone through some of the accomplishments, so I'm not going to read this slide. Just to know that this year we are really planning to talk to more legislators in advance, not just IPHI, but also working on those communication tools so community health workers and supervisors and hospital system representatives can talk to legislators. So we are gearing up and planning for that. We also have a video, a community health worker video that is almost finished. So that will be released soon and give an opportunity and more information about community health workers as well. Next slide. So this is just a picture of Centara. Laura might have one on hers, but this is from Advocacy Day. Their group had the biggest turnout. They were also the only group that took an official photo, which we were very thankful for. So I see Laura in the middle, but it was a great day, and we really appreciate everybody's support moving forward. And then my last slide is just my contact information. If anybody has any further questions or does want to attend a meeting, if you please will just get in touch with me. I welcome that. So thank you very much for your time.
Wonderful. Thank you very much, Sonia. That was an excellent overview to how community health workers are being defined in Virginia and all the great activities that IPHI is leading in Virginia around this effort. So, and your reference to Laura was a beautiful segue to our next presenter, Laura Watson, who is the Continuum Integrated Care Manager with Centara RMH in Harrisonburg, Virginia, who will speak to us about optimizing care transitions through an integrated partnership with continuum case managers and community health workers. So welcome, Laura.
Thank you so much. I'm so excited to be able to share with you the work we're doing here at Centara RMH and how we've incorporated community health workers into our case management program to really impact the quality of life for our patients. Next slide, please. So we have a pilot study, and our objective was to look at quality of life. Could we impact the quality of life for our heart failure patients? Could we decrease readmissions, decrease ED visits, and decrease overall health care costs by incorporating community health workers into a program that we already had existing, a continuum case management program. So let me go to the next slide, and I'll share with you what our initial program was. Continuum Case Managers is a very unique position. We're the only Centara facility that is currently utilizing case managers in this role, and our purpose is to help ensure a smooth transition from hospital to home or from a skilled nursing facility to home for those patients who are deemed most complex, those who are highest risk for readmission, whether it be from multiple comorbidities, multiple discharge planning needs, lengthy hospital stays, or just has a history of admissions. The case manager would meet with that patient in the hospital, explain the program to them, and then meet with them at home, do home visits, and really assess what their needs were. Thorough medication reconciliation process was done, ensuring that the patients knew what medications they were supposed to take, how they took them, and if they had ability to afford their next month's payment. We also ensured that they had follow-up appointments and that they had means to get to those appointments. In addition, we would follow up with the patients through phone calls or additional visits if it was deemed that it was necessary. Next slide. Reflecting back on our program, we found that yes, we indeed were successful. We did have decreased readmissions and ED visits, as well as decreased costs for these clients. But what we realized was that the nurses were spending a lot of time doing non-nursing related activities. Almost about 50% of the visit or office time was spent on looking at financial applications or filling out transportation, providing transportation applications or Medicaid applications. And this really was not something that required a nurse to do. This was hindering our ability to impact the amount of patients that we could actually serve. So we needed to find a better way. What could we do to be able to impact more patients and yet meet these physical and social and medical needs of our clients? So we did a review of the literature, and next slide. That led us to the community health worker role. Community health workers just might be the answer to our problem. They would be able to help navigate the patient through this complex social needs that they have, and the continuum case managers would be helpful in navigating the medical problems of these clients. Next slide. So we received a grant from our foundation for an 18-month project that would support 3 community health worker positions, and we were going to partner them with our 3 continuum case managers. So we were going to do a one-on-one partnership. Our criteria for our patients were the same as prior. If the patients were deemed high risk for readmission, then they would be eligible for our program. The unique aspect of our continuum case management program is that we are a free service. There's no charge to the patient or to insurance. We are a return on investment type of a program. So if the case manager met with the patient and determined that they had needs that the community health worker would be able to meet, then we would make a home visit together and would develop a plan of care with the patient, the family, as well as the continuum case manager and the community health worker. Next. Our study took place at Sentara RMH Medical Center and its surrounding community. Our goal, once again, was to ensure a smooth transition of care from the hospital to the home so that these patients were set up to successfully self-manage their chronic condition. Our patient population was the heart failure population. As I'm sure you're aware of, that is one of Medicare's highest readmission groups. Over 24% of patients come back to the hospital within a 30-day period. So our goal was to see, could we impact this and help these patients successfully not only stay out of the hospital, but learn how to manage their chronic condition. So the community health worker and the continuum case manager would meet the patient in their home and together would develop a plan of care. Next slide. So what is our thoughts for this community health worker? What would they be doing that would not overlap what the nurse would be doing? Well, a lot of it would be health education. The community health worker was an integral part of teaching self-management skills to our patients. Heart failure is a very difficult disease to manage, and it requires a lot of education. How to properly identify signs and symptoms of heart failure, such as swelling in their ankles or shortness of breath or weight gain. So that the community health worker would reinforce that teaching, would call the patient up and see how they're doing. How is their weight? How are they feeling? They would help them navigate through this complex system of getting rides to their doctor's appointment or getting SNAP applications filled out or Social Security benefits met. They would also be able to look at vital signs. Like I said, weight. Is their weight going up? What is the trend of their weight? And would be able to help the patients then know what to do if that situation was occurring. Would they place a call to their family physician to say, you know, that their weight is going up and they might need an intervention by the doctor? So whatever the non-medical needs were, that's what our goal was for the community health worker. Next. It takes a village to really manage these heart failure patients. It's a very complex process, and our community health workers were an integral part of this process. They would meet with patients in their primary care visits. They would attend the visit with the client and help them to address concerns that they might have. They would call pharmacists if their medications were running out and they needed refills, or speak to the patients about hospice needs, anything that they could possibly identify as a need, they were able to really integrate with all of our community partners. Next, please. So what we looked at here was what were we going to determine with our program? What goals did we want to look at? So we wanted to ensure that we were appropriately using our RNs and our community health workers in their proper roles. We were going to use the Minnesota Living with Heart Failure questionnaire as our tool, and I'll go into that in a little while and explain exactly what that heart failure questionnaire is. And then we were going to look at access. Were we able to decrease readmissions, decrease ED visits, and overall decrease the healthcare costs? And we were utilizing the patient's electronic medical health record as our source of data. Next, please. So our design was, and similar to before, the case manager would determine if the patient was appropriate for services, and then we would go to their home, we would get consent to have the patient in our study, explain what the Minnesota Living with Heart Failure questionnaire was, and what the purpose of our study was. Since this was a grant-funded project, we really needed to determine to our benefactors that this was an important role and that the community health work could really have an impact on our patients' lives. So once we got consent from the patient, the community health worker would do the Minnesota Living with Heart Failure questionnaire. And this is a 21-question survey, and it deals with not only physical aspects of heart failure, such as does making heart failure make walking or climbing stairs difficult? Does it make you have swelling in your ankles or legs? Does it make you sit or lie down during the day to rest? But it also deals with emotional aspects, such as does heart failure make you feel like you're a burden to your family or friends? Or does it make you feel like you have a loss of self-control? One of the things that I found, and I had been working as a continuum case manager for over 2 years, was that incorporating this study into the home visit was really a life-changing thing for me. Once you started asking these patients these questions, the feeling in the room was palpable. The patients felt like such a relief that they were able to share that, yes, indeed, they did feel like a burden to their family. And 9 times out of 10, the caregivers were so surprised that this was a thought in their mind. They had no idea that they felt like they were such a burden. And there were tears that were shed, and it really gave the whole family an opportunity to discuss this. And we were then able to take a look at this survey, and the patients would rate it on a scale of 0 to 5 on how much heart failure was impacting them. And then we would tally up all of their highest scores, and I would address their medical ones, such as their swelling of their ankles or their shortness of breath. And Gina then would work on the physical, the emotional aspects, such as how they feel like they're a burden to their family. And we would sit with the patient and their family and develop a plan of care. We would divide and conquer. How can we help this patient not have such an emotional and medical stress due to their heart failure? So this survey was done initially on our first visit, and then once again 3 months later. So this was a 3-month project that we tried to really help the patient learn how to not only self-manage, but once again address these physical and emotional needs. Next. We had 41 patients in our study. We went from April to September of 2016. We looked at 3 months prior to our initial visit and then 3 months after. That's how our data was collected. And as you can see in the next slide, we really had some great success working together with our partnership. The physical and emotional dimensions, the pre was our initial visit, scored very high with our clients. They were not only having obvious physical problems affiliated with heart failure, but also emotional ones. And if you can see the next little slot after the post, it was significantly reduced. Sorry, could you go back? There you go. The physical and emotional aspects that the clients were presenting with were significantly decreased after our 3 months of intervention with this client or clients. Next slide. Not only were we able to address the physical and emotional aspects, but we had a great impact on the total admissions and total ED visits. Prior, we had 84 total admissions of this 41 patients, to the hospital, and 3 months after, we only had 17. The ED visits, there were 74 ED visits prior to working together, and then only 18. So as you can see, it was a significant impact, both physically and socially and financially with this patient population. Next slide, please. In addition, we also met the criteria that we had looked at initially. We were appropriately using our skill mix. We were able to divide and conquer with these patients, and the nurse was able to address the physical and medical needs, and our community health worker was able to appropriately navigate them through the healthcare system. We did this by providing education. Our initial visit was very comprehensive. We went over all of their medications one by one, the nurse did, and explained to the patient how to take them, ensure that they were properly taking their medications. We talked about the signs and symptoms of heart failure, how to identify them, to weigh themselves daily, to check for swelling, and not only that, but how to then address them. Educated the patient on how to call their family physician and say, this is Mr. Smith, my weight is up by 3 pounds, I'm a heart failure patient, what should I do? And the community health worker was very integral part of that by really reaffirming to the patient how to do that with their phone calls. She would call them up weekly or visit them and make sure that they were complying with all the education that we had provided. In addition, she would ensure that they could get to their follow-up appointments and would help with any transportation needs. On an average, there were 1 to 6 referrals that were made based on our interventions, referrals such as Valley Program for Aging, Meals on Wheels, paratransit, or social services. Finances, as you can see on the slide, total charges compared to 3 months pre and post, we were able to decrease charges by 79.2%, or $846,225. So that was a significant savings to the hospital. Next slide. So in conclusion, adding the community health workers to our program has been, personally for me, a wonderful addition. My patients, or our patients, have really benefited by being able to meet their needs physically, mentally, socially, and to be able to help them learn to navigate this very complex system. And as you can see by our study, we were able to not only improve their quality of life, but decrease readmissions, decrease ED visits, and decrease overall healthcare costs. Thank you.
Laura, again, thank you very much. It was wonderful information. Thank you for sharing all the great work you guys are doing there at Sentara RMH. We will now move to our final set of presenters. Dr. Walley Smith is the Florence Neal Smith Cooper Professor of Medicine in the Division of General Medicine at VCU Health in Richmond, and his colleague Shirley Johnson is a Research Operations Manager and Patient Navigator Supervisor, and they will talk to us about community health workers for chronic disease management, the approach that they've taken at VCU. Dr. Smith and then Shirley, glad to have you all with us this morning.
Thank you. Shirley has told me I have to do most of the talking, but she'll answer any questions you have.
Okay, great.
We're going to talk about the value proposition for community health workers and then mimic many of the things you've heard from the previous two presenters in describing community health workers, taking a very broad definition approach. Our definition is in part broader from the strict definition of a lay person that you've heard earlier. We agree that that is definitely a type of community health worker, but we think a broader definition of community health workers includes non-lay people, as has been intimated in the second presentation, and we'll show you what we mean a little bit later. Next. We also agree that community health workers can impact each of the arms of the triple aim, and in particular, the one I want to focus on today is cost. The health of the population is, of course, something that a public health perspective would be expecting these workers to improve. And then the experience of care, I think, goes without saying when you have race and culture concordance with worker and with patient. Other thing I wanted to show is heart failure, certainly one of the places where the type of worker and the type of programs that these workers would be working in have been used most often, but also asthma, hypertension, diabetes, and HIV. And in each of these diseases, you can read the literature and find lots of instances where these kind of people have been implemented and where positive results have happened. And you can see that prevention and healthcare self-management, in addition to disease management and disease prevention, can be shown to be impacted. And then in yellow, I want to focus on utilization as an aim for those who are interested in showing how these can be used in a cost-beneficial way in a healthcare or hospital system. Next. Under value-based payment, CHWs obviously should save money if you are prospectively paid by preventing readmissions, shortening the length of stay, by improving healthcare maintenance and self-care, and lowering the cost per patient for care. Under fee-for-service payment, on the other hand, if CHWs are used appropriately, they can be used in a billable way. But more importantly, they give that patient satisfaction side of the triple aim some increased impact by showing high-touch care and by showing a healthy human side to an otherwise hard-edged healthcare system. Things like helping the patient keep their appointment, telling them where the bathroom is, telling them how to get to the clinic, how to navigate around sometimes a difficult healthcare infrastructure so that the patients feel more cared for. You might be accustomed to seeing cancer care centers of America advertising using community healthcare workers in the front of their advertisements to show that it's a better system because of them. Next. So these people do fit in a healthcare team. They do share responsibility along with others for the care of the patient. Has been mentioned, they may be taking blood pressures, they may be providing support and social services, they may be doing patient education. And then they also really want to get down with the patient. And this is where their credibility and conformity to the patient's identity is the most important. By empowering those patients to say, if I can do it, you can do it, empowering them to sustain disease management, comprehensive disease management, and helping to bridge trust gaps between the patient and the healthcare system. Next. So our broader definition of community health workers shows that sometimes their training and background and job descriptions may overlap with other healthcare workers in the system. Even though they are primarily not biomedical personnel, they may sometimes do the job of a nurse's aide, a home health aide, a public health nurse, or a social worker. Things like taking the blood pressure, as was discussed earlier, getting someone some public assistance or insurance help, depends on the job description. So the job description, in our opinion, determines the amount of overlap with these other potential members of the healthcare system, and one size does not fit all. Next. Some core roles that I think are emerging as definite places where CHWs have strength. I've already mentioned cultural mediation, the bridge, the trust gap between the patient and the healthcare system, informal counseling and support, education, advocacy. This is a very important role. And often CHWs are chief advocates for their patients, assuring that people get the services that they need. They may not provide the service themselves, but they are assuring that the patient gets the services that they need. And then building individual community capacity, as it's been said. If you're in the community already and you have the trust of the tribal elders, you're more likely to be able to build community and social capital, and you're more likely to be able to represent what that social capital means to powerful others in the healthcare system. And then last, sometimes providing direct services. And the rationale for why community health workers can help patients has to do with Bandura's social learning theory and the idea that behavioral variables are very powerful drivers of health, so that the understanding of health is that it is primarily socially driven, and that biomedical impacts are not nearly as important as we once thought, and that this behavior can be shaped by social others around the patient, by feedback from objective sources, using that appropriately, and by the emphasis on the culture and the traditions and the belief that patients share with the potential helper, such that the patient feels that they're being holistic in improving their health and in staying culturally identity, maintaining their cultural identity. Next. The important point I want to make is that a CHW is not a CHW is not a CHW in our experience. Again, job descriptions can vary. These people can do things like help get social network established, help get insurance, help navigate the healthcare system. There's a number of descriptions of jobs that we think should be called community health workers, but those jobs are quite different. Next. We also think that the level of training and the level and the type of background for community health workers can vary. So we have an informal definition of a peer level or community health worker who shares strong cultural conditions and demographic conditions with the targeted population and has high credibility with their clients, but may not be highly technically trained. And I think there is a trade-off as you go toward the right and you get more training. You may have more cultural distance from your clients. So on the extreme right-hand side, there's controversy about whether a nurse can be a community health worker. But if they were and had that clinical background, obviously they're going to have a lot of sophistication. They're possibly going to have more cultural distance from their clients, even though they're trying to do something that is different from the traditional nurse job description and similar to a job description that others might do. And this creates a goal conflict sometimes. If the hospital is hiring these people, sometimes the hospital has the goal of decreasing costs, whereas the client has the goal of increasing service. And so you have to think about all these things as you employ community health workers. But having said all of that, we still think that the idea of having these workers in the healthcare workforce is a very good one. And in the end, as long as you are walking in with your eyes open, that you're going to be better off having these kinds of people in the system. Next. How do you pay for them? The Patient and Protection and Affordable Care Act, still intact, gave the ability to, quote, award grants to eligible entities to promote positive health behaviors and outcomes for populations in medically underserved communities through the use of CHWs. Medicaid put a final rule into effect for children so that the essential health benefit and alternative benefit plans and others might allow for the payment for non-licensed individuals to provide preventive services. Other than that, it's grant funded at this point. There's not a lot of opportunity for individual CHWs to bill service the way a nurse would, the way a social worker would, the way a doctor would. But the idea of saving money as well as billing through CHWs, I think, is here to stay, and we're going to see, I think, at some point, the ability to bill for these services specifically. Next. As you've already heard, the area agencies on aging are already using these workers. There's names for them like health coach. The hospitals are using these workers. There's names for them like the one you just heard. And at VCU, we use the word outreach worker sometimes, case manager sometimes. The Virginia Department of Health has a program, an old program called Resource Mothers. It's been around for a couple of decades probably, which has been very successful and has very good outcomes to show. Public health kind of use. And then managed care organizations interested in saving money under prospective payment, either Medicaid or Medicare, have employed these individuals. Obviously, the goal there is chronic disease management, preventive health care management to reduce costs, reduce readmissions, reduce admissions. The behavioral health authorities have something called the mental health caseworkers that run around with patients, and sometimes they have very little formal training, but are just peers from the community designed to help mentally challenged individuals. There's a system, an entity called No Wrong Door, which I believe Senator Warner helped to found, which has been using these individuals. And so there is a workforce as yet not completely counted in the state that is working in each of these types of entities. Next. So I described for you today what we're doing at VCU to utilize these community health care workers. We have something called a complex care clinic, which I will not describe, but which is self-descriptive. And in there are 2 or 3 kinds of community health workers with 2 or 3 kinds of names, with 2 or 3 levels of training, each designed to try to help patients navigate the system, stay out of the hospital, take better care of their chronic disease, and we're talking about heart failure and diabetes and hypertension. And then the Geriatric Center for Healthcare Management has its own building and its own set of workers. They make home visits with doctors sometimes, with nurses, practitioners sometimes. And then we have a partnership with the Capital Area Agency on Aging. The Area Agency on Aging is a regional program, and so the capital area has partnered with us, and I think they also partner with Bon Secours. The health coach that we have there is a person who's taking care of about 25 patients, doing about a 4-week intervention on each patient. These are patients coming from our hospitalist service, and we're trying to reduce readmissions there. We're collecting information there. Of course, with one worker, it's difficult to get a very robust evaluation. Our heart failure program was funded a couple of years ago and has begun to use community health workers there, similar to what you just heard. And then we're going to talk about my program, the sickle cell program. Next slide. First of all, we have a federal grant that will do a rigorous evaluation of the value of community health workers, both financial and the other parts of the triple aim, for patients with chronic disease, and in this case, it's sickle cell disease. So this is a federally funded opportunity. Next. The first specific aim is to show how we are using the term patient navigators to brand our community health workers, to show how patient navigators improve the intake of patients, case finding of patients with sickle cell disease. And we're all over the state in the Richmond and Tidewater regions and trying to get people into sickle cell disease specialty care. Those who don't know, sickle cell disease is a fairly rare disease, chronic disease that ends life prematurely, and without specialty care, patients often die. Next. The second specific aim is to show that taking the one and only drug that's been shown to prolong life in sickle cell disease, hydroxyurea, whether getting these navigators involved in the patient's lives will get the patients to take their medicine better, either to start taking it if they're eligible or to take it better. And again, we're looking at those who are eligible and in the Richmond and Tidewater regions. So for these programs, we're going to have in about a year rigorous evaluation of the impact of community health workers on a chronic disease. I put in red here for the financial people that are listening that we will know whether they reduce hospital admissions with rigor, whether they reduce emergency room visits with rigor. We will know above there whether they improve disease outcomes related to sickle cell disease, the total hemoglobin and the white count. We'll also understand a little bit more about the health-related quality of life. These are standardized measures of health-related quality of life. And then below there, we'll also know something about the adherence rate to the medication, and we'll know a whole lot about being able to measure how much of the medication the patients get to. MTD has to do with maximally tolerated dose. So we're going to be having some pretty rigorous measures, this demonstration program that's been funded by the feds. But wait, there's more. Next slide. So I want to tell you about a case study where we borrowed, and don't tell anybody, money from the federal program that we were funded and took some of these navigators and actually looked at high utilizers in our hospital to see if we could reduce unnecessary utilization. So in this case, we're using these patient navigators as part of a team, a physician, a physician's assistant, and then the navigators, and sometimes other members of the team would participate, but the basic members of the team were those. Next. And this was in response to the hospital's cry for help with an increasing length of stay and an increasing volume for patients with sickle cell disease in the past 5 years. We only focused on the 5 highest utilizers. We call them the red group, and we try to monitor and to intervene on their utilization and their determinants of health over about a 15-month period. Now, one of the patients died early in the program, and another one had a little too much monitoring and left the system. And so we had 3 patients then who got about 1.5 years of intervention. Next. One of these cases was a 27-year-old man who had a transplanted kidney with stage 2 kidney disease, post-traumatic stress syndrome, depression and anxiety, DVT of the extremities, migraines, an unspecified cognitive impairment. He liked to claim that he was in college, but whenever we checked, we never found that to be true. Look at all the interventions that we had to do in order to try to get his case under control. And this is where I make the point that you don't often know what the job descriptions are going to be required. And so when people are working in teams, there's some handoffs that have to happen. But all of these interventions needed to be done. And I won't read them all, but you can see that just a lot of different kinds of interventions that were required over time. Next. So with that intervention on those 5 patients, we were able to show in the top right-hand side an impactable savings of $326,435 for inpatient discharges alone. That is 32 fewer inpatient discharges over the time period that we studied. Dropping down, we were able to show a very small change in the number of ED discharges, 3 less, for a small savings of $7,404. And then in yellow further down, we were able to show a change of 240 days, or a drop of 240 days in length of stay. And then a total cost pointed to with the blue up arrow of $333,000 in savings, about a 35% savings just for the red group. Now, if you were to extrapolate that to the yellow group, the next row down, and look at the total possible savings, we think it could be as much as $1.5 million in the green box there at the bottom, as much as $1.5 million that we could save were this program to be as effective. But let's suppose it weren't. Let's suppose it were only half as effective. You're still talking about a savings of about $700,000 for extrapolating forward for the untapped potential savings for this program. Next. So I hope I've convinced you that CHWs have well-defined roles within hospitals and health systems, core roles for patients and patient care, that they can be used and defined in many flexible ways, that they are valuable and attractive regardless of the payment system that you live under. They can save money in prospective payment. They can make money under fee-for-service, that they help fulfill the triple aim of improved health, improved satisfaction, and lower costs.
Dr. Smith, thank you very much. That was excellent. Thank you so very much. We will now move to the question and answer portion of our program. We do see that there are a couple of questions already in the chat box, and so I will have my colleague Betsy Cole facilitate those questions. I think they may be responded to by any of our speakers, and then she'll explain to others if you want to ask a question either through the chat box or verbally how to do so.
Thanks, Abraham, and thanks to Jennifer Robinson for getting us started with our question and answer session. These questions came in during Laura's presentation, but I do know that I think Dr. Smith touched on some of these issues as well. The question is, what is the education level of your CHW, associate's degree, certifications, etc.? And again, Laura, this is for you, but others may answer as well.
Okay, thank you. Yes, our CHWs have all have bachelor's degrees, and then they did receive training through the Virginia Department of Health for community health worker training, but they all have a 4-year degree. That was not a requirement, but we were fortunate enough to get that level of education.
And then go ahead.
This is, hello?
Yes.
Yes, we hear you.
This is Dr. Smith. I'm going to answer 2 questions. I'm going to answer the question of what we actually have now, and then I'm going to answer the question that maybe is underneath that question, what's necessary. What we have now is we have 1 clinical social worker and 1 less than bachelor trained person, both of whom are functioning as patient navigators in our sickle cell disease program that I just described. I can tell you that in the complex care clinic, we have high school educated only CHWs, we have college educated CHWs, and we have some in between. What is necessary, we feel, is something less than an associate's degree for the level 1 job description that I described and that IPHI is, I think, most in favor of. I don't think you even need an associate's degree for that. You need training, but you don't need an associate's degree. And I think the training really needs to be specified for the job that you're going to do. I think there's some minimal core competencies that we are really zooming in on based on our experience, that those core competencies do not have to be obtained at a college or community college.
Yeah,
Great, thank you.
I mean, just looking from the advisory group standpoint, and I don't sit on the certification committee, and I was trying to find the latest document, which I can't find right now, but they're looking at 2 different levels and using a high school diploma kind of as the marker to differentiate the 2 levels. And then, like I mentioned, they're looking at the different type of trainings and how they're going to grandfather in and different things like this. But one of the things we can't overlook is, you know, we have different types of communities. So if you're looking at, say, a refugee community, we acknowledge, we meaning the whole advisory group, acknowledge that those community health workers are extremely vital and important and not doing any different type of job and are no less important just because they don't have a high school diploma. But we recognize that coming from a different country that there are community health workers that aren't quite at that level. So the way that the latest draft I saw is looking at 2 different levels with the high school diploma kind of differentiating between a level 1 and level 2.
Great. Thank you all for your comments on that. As a follow-up question, which I imagine the answer is going to be it depends or it's variable, but the follow-up question is what is their average salary, and do you have a scope of practice? And Dr. Smith, you kind of touched on the scope a little bit in your tiers, but any comments about the salary?
Well, like I told you, Shirley's going to answer all your questions.
So we have actually, through the institution, determined that the average salary is between $33,000 and $36,000 for a person functioning at the level here. And some of that's based on experience, but we felt that it was important to maintain the quality of a navigator and not have high turnover. And by being able to offer a comparable salary with benefits, we've actually been able to sustain the navigators that we have here, both in the sickle cell program and in the complex care program for several years. So we did feel that the salary was very important to recognize sustainability for the populations that we're serving.
Great. Thank you. Any other comments about salaries from our panelists?
This is Sonia. I actually don't know for IPHI what we do pay those that are in our housing advocates or housing authorities. But the second part of that in terms of scope of practice, the advisory group does have core competencies and scope of practices already finalized. And I would be more than happy to send that to you guys, and you could send it out to the participants if they wanted to have a better look.
That would be great.
This is Shirley again. The other thing that I wanted to kind of lead into as well is the extensive training curriculum that our program involves at this point. Joan Quarter-Mabe and I have put together a very strong didactic training program, not only based on core competencies, but other factors like motivational interviewing, health belief model, the medical terminologies that are important to the different populations that we serve. And we have found throughout the time of our project that it has evolved, and we also have started incorporating the more person-centered planning concept that we feel is extremely important to make sure that not only are the healthcare system's needs getting met by ensuring that the patients maybe are receiving the services they need outside the institution and don't need to come in as frequently, but that we're also honoring the respect of the patients and trying to give them some motivation to be able to want to work harder to try to stay more healthy.
Great. Thank you for those comments. I will remind the participants that you can type your question into the questions portion of the GoToWebinar portal. If you dialed in using your phone, you may also raise your hand to verbally ask your question of our panelists.
So it looks like we have no more questions in our question box. We're scrolling through the list of attendees and we don't see any hands raised. And so perhaps we'll take that as a sign that our presenters were extremely comprehensive and they anticipated every single question that folks might have and did an excellent job in responding to them in advance. So with that, I am going to extend another very big thanks to Sonia, Laura, Dr. Smith, and Shirley. We appreciate your time this morning. We appreciate your preparation for this webinar, and most importantly, we appreciate the work that you're leading in your respective organizations to better serve the patients that you have the honor of caring for, and for being an example of how others in Virginia can help us pursue our goal of being the healthiest state in the nation and by achieving the triple aim. When our next webinar is scheduled for May 17th at 10 a.m. in our Home is the Hub series. Our plan at this point is to do a deep dive webinar on the topic of hospital and skilled nursing facilities. We hope that you'll be able to join us. When you log out of this morning's webinar, you should receive an evaluation. Your feedback is very much appreciated, so please take a few minutes to answer those 4 or 5 questions. And finally, we thank you for your commitment to reducing preventable readmissions in Virginia, and please have a great day.
Thank you for having us.
Thank you all.